Hello, welcome to HLA Live. HLA Live is our regular broadcast on the HLA YouTube channel as well as all the other social media channels. Each week we talk to interesting people from across the HLA community.
Good evening, everyone. I am really excited to be chairing tonight's meeting.
Hi, I'm Rosie Spooner and I'm hosting HLA Live this Wednesday.
And I'm an HLA scholar and I'm also going to be your host this evening.
To share with us their ideas and their innovations and hopefully bring them to a global audience.
Quite quick, we have ideas, let's do this, let's do that. So
many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have.
Hello everyone and welcome to the HLA Live session on widening participation in the postgraduate realm.
Homelessness and health.
Addiction and the new normal.
HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur. The leader is a communicator. The leader is a manager. The leader as a negotiator. The leader as a follower. And the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty. Episode 42 of HLA Live is entitled Palliative Care and Junior Doctor Training, a European Perspective, and is hosted by Annalot.
Hello everyone and welcome to this episode of HLA Live on Junior Doctors and Palliative Care. My name is Annalot van der Meulen and I'm currently a junior doctor in the Netherlands, and I'm also a palliative care fan. But back when I started working, it wasn't like that. Death, dying, end-of-life care can all be quite a scary topic for junior doctors, especially when it has been shown that medical curricula across Europe and the UK don't necessarily adequately prepare junior doctors to be able to deliver palliative care in their first job. But when I started working in my first job, I realized however complex palliative care is, it is also intimate, beautiful and rewarding to bring comfort in the last days of a patient and family's life. And it has a lasting impact on both you and the patient and family. And so the aim of this episode is really to tune into how can we instill more confidence, more knowledge, more skills in junior doctors with regards to palliative care. And so we first will be speaking to some junior doctors about their frontline experiences with palliative care, after which we will move on to 2 senior healthcare professionals talking about palliative care, education and leadership. Can you briefly introduce yourself?
Hi, my name is Katie. I'm currently a PhD student at the Amsterdam Medical Center at the Department of Neurology, and I've worked the past year as a neurology, resident, but not during residency, in Leeuwarden, the medical center in Leeuwarden.
Hi, my name is William Hull, and I am just completing my last few weeks at the University of Birmingham Medical School, about to become a junior doctor in London.
So my name is Anne Meyercourt. I'm a foundation year 1 doctor currently based in Germany, and I studied medicine on a course between England, so between Southampton and a hospital here in Germany in Kassel. So I got to experience 2 healthcare systems at quite an early stage, and currently doing my F1, which is overseen by the Wessex Foundation School.
I'm Rosa, I'm 28 years old, and I'm working as a junior doctor in the palliative care in a hospital in the Netherlands.
And could you tell me a little bit about how you feel about palliative care, what palliative care means to you?
For me, it's very important. That's why I'm doing this job now. I'm the only junior doctor in the Netherlands who is not in training, who's doing this job. So I'm very lucky I can do this. And for me, it's a really nice work field because I can have time and I can have a lot of interest in the whole patient and not only one problem.
Well, I always found it a little bit of a frightening topic, a little bit awkward, a bit, I never really knew how to discuss it, how to talk about it, especially with patients. As a student, we had a little bit of a contact with it, but never really. So I after working a bit in neurology, I found that although I found it in the beginning a little bit difficult, it can actually also be a beautiful experience, and you should just be able to make as much out of it as you can.
I think it's a very personal area of life, isn't it? You know, everybody dies, but what is a good death, and what is a good end of life? It's something that for a long time has been very, very personal. You know, back in even 50 years ago or so, people would have been dying alone in their homes, surrounded by their families. And to a certain degree, we've medicalized it. And I guess the discussion as to whether that's a good thing or not is for another day. But just to be involved in that yourself, to be a part of that inner circle of saying goodbye to that person and being involved in those final steps, I think is a huge privilege.
Yeah, I think palliative care is a very important discipline in medicine, which is often underestimated how much benefit it can actually give to a patient and their loved ones, and who face a serious illness and lifetime limiting illness.
I think palliative care has to evoke kind of feelings of sadness to a certain degree. I think you're not human if you don't sort of feel a little bit sad about the thought of treating someone at the end of life. But at the same time, I think it's a real privilege, and you know, being involved in those kinds of decisions towards the end of someone's life, about how to treat them, about how to keep them comfortable, and also about treating the environment around them. So about the family as well. You know, it's not just one patient, it's a whole number of patients. And I think there's a great privilege to be involved in any sort of palliative care and end of life decisions.
How and when did you learn first about palliative care? And can you tell me a little bit about formal training, if you've received any at all?
Yeah, I think we had actually already a few lectures sort of in first and second year about palliative care, which are quite theoretical.
We've studied a little bit of palliative care more in the discussions during the studies, but actually I think the most important first meeting, the first experiences are actually in practice, where you obviously have to stand across from a person who might be a palliative care candidate and their family.
I don't think I received formal training during university, and if I did, then it was just a little bit. So
here in Birmingham, there's a thread that runs through all our medical training of palliative care. It starts off with some sort of views of palliative care consultants, just suggesting to us, you know, introducing us to the kind of tools that you can use in palliative care for symptom control, some of the very medical side of things. And of course that's interesting, but it's difficult to put that in context when you're very early in your clinical career. As you move on through the medical training, actually have hospice experience days, whereby you go into hospice, see what the hospice is all about, speak to some patients in the hospice environment, speak to some families, and really see the whole process that goes on in there. But actually what was really important for me was we also got the opportunity to go out into hospice at home, into the community, and see some of the patients who were under the care of the hospice and the palliative care team, but were actually wanting to spend their last sort of days, weeks, months at home.
In my clinical years, I actually had quite a lot of exposure to palliative care as well. So during my GP placements, we actually did visit a hospice here in Germany, and we could speak to the management of that hospice, and they talked us through some cases, what they're doing at the hospice, what they can do, what they can offer to patients and their loved ones. And then I also had some more clinical exposure in my oncology week during my final year. And yeah.
As a doctor, I wasn't a doctor at the time, but as sort of a doctor position, you are someone who is there to listen to a lot of the things that they can't say to their family. And you can have a very open and frank discussion.
Because I think in society, it's still a topic that's not spoken about a lot. It's still well, not sure if stigmatized is the right word, but it's definitely not a topic that's talked about a lot. And so yeah, I think that definitely helped to take away that fear.
So although we did have a bit of a preparation in terms of reading up on it and talking about it with each other, we never really had the opportunity to the first time you experience this with real people is when you stand there in your white coat trying to figure it out how to deal with it.
But I think actually the first time that I was really encouraged to think about end-of-life care and patients who are at their end of life was in my second year of medical school, where I chose a student-selected unit themed around death and dying. So this was a course basically that you could choose. You didn't have to do it. And there were several to choose from on different topics. And I chose the one around death and dying. And that was actually really, I very much enjoyed that course because it encouraged us as medical students to think about death in quite a creative way. And we basically just talked about it. How is death presented in that resource? So it was films, it was books, podcasts, could be anything, academic literature about death and dying and palliative care. And I think these conversations really, encourage us to think about it in a creative way, but also took away that fear of talking about death in sort of the first place.
I think I learned the most from my peers, not from my supervisors. I think we, as doctors who are standing next to the patient and next to the bed, we saw earlier that it was the end of life or that there was more care necessary next to the chemotherapy or other treatments. And I learned from my peers, and there was a specialized team in the palliative care in the hospital who you could ask to help you and think with you how you could do it better and how you could take care for the patients.
I would say medical school has definitely helped me to lose that hesitation or fear of addressing death and end-of-life care with patients and talking about it. But I would say, no matter how well prepared you are or how many sort of clinical scenarios you have observed or trained OSCEs in, I think you will still feel extremely nervous when you have your first consultation with a patient around their end-of-life care. I think it all came really down to just being an empathic doctor and really seeing that individual patient in front of you. I think that's definitely, that approach has helped me a lot with sort of taking away that nervousness in my first consultations now in F1, speaking with patients and their loved ones.
And I should say that my experience of palliative care has been very much something that I've really taken upon myself to appreciate. I don't think it's something that gets picked up on enough. As much as we had some formal teaching over the 4 years that I did, we probably had 5 or 6 formal days worth of teaching focused on palliative care. I think actually what needs to be done is to pick up on palliative care opportunities more so in the hospital. Like I say, when you're in an acute hospital, somebody needs to say, hang on a minute, this is an end-of-life care decision that we're making here. And it needs to be not necessarily formally, but more informally recognised that when we're giving these care, when we're making these care decisions, they're actually end-of-life care decisions, and perhaps that can help us to make them a little more thoughtfully.
Yeah, so what I maybe would have hoped sort of for courses who, or what I think my medical school did actually quite good, was that mix of theoretical teaching as well as clinical experience. And also, I think I was quite privileged in that sense that I had that extra course of around death and dying in my second year of medical school. And I'm quite aware that maybe another student might have not had that same experience, and I did. But I think just really these creative approaches, I think they are really useful in bringing young doctors, getting them in touch with end-of-life care.
Yeah, so did you feel adequately prepared to handle certain palliative care situations already while in your rotations, or maybe now in your first job? And if not, or if yes, how come?
Well, I feel like that's a tricky question if I was adequately prepared. Or, to be honest, I don't think you can be adequately prepared to any of those situations. It's just like we practice giving bad news, but the first time you have to do it yourself with a person who actually has, let's say, cancer, it's very different.
I don't think one can ever be prepared for making those kind of huge end-of-life care decisions. And of course, it's not for us to be making those, it's for the patient and the family to be making those decisions at the end of the day. I think I do feel fairly well prepared for the medical aspect of it. I feel like I have a good enough understanding from my teaching that I can appreciate how to treat things like pain towards the end of life, respiratory distress, agitation, secretions, all of these sorts of things. I think those are very medical, but actually in terms of delivering that care, which I will be doing in a few months' time, I don't think everyone can ever really be prepared for that, and that's something I imagine comes with experience.
And I think for all the junior doctors, the night times are different, and then you have to do a lot more by yourself. So I thought I was prepared, but when you're there in the night and a patient is dying, then it's a different situation. So I knew a little bit, but when I was doing it in the night on my own as the only doctor, then I would like to have known more than I did.
It was an issue for me. I found it very difficult to accept that she can just do nothing. Well, obviously you're helping people to pass away in a decent manner, but I saw it in the beginning as just doing nothing and letting somebody go and letting somebody die. So I found it very difficult, and only after I've seen a few people receiving palliative care and I've seen in what situations those things happen, I only understood what that actually can mean, and that it can actually improve the feeling that the family gets, and how that actually is the best choice that you have very often. So that's I feel like talking to people and seeing things helps the most.
I think maybe just also another sort of fact from medical school that had stuck with me, was that statistic that was often quoted, that when you actually ask people where they want to die, that most of them do say, well, I hope to die at home or in a hospice. But then actually the reality is that most of people actually die in the hospital. And I think just this figure has always sort of stuck with me and really encouraged me to think about and make that extra sort of conversation and with my patients, and making that extra effort of seeing, well, can we do something to help them get their wish fulfilled? Because I think it's just a statistic that has sort of really shocked me, that there's such a big discrepancy between the two. Yeah.
Is there anything you would have liked to have known about palliative care, or certain skills before you started your first job as a junior doctor?
I think the skills that I would have wanted, I think I would have wanted a bit of more knowledge about what it actually means, and what it also just medical knowledge, because what you learn from the older colleagues. So the fact that people, they look uncomfortable sometimes, but that doesn't mean they are uncomfortable. You have to know that to be able to tell it to the family, because if you walk in the room and it's middle of the night and you have your it's one of your first nights that you have, and somebody is receiving palliative therapy and they look uncomfortable, and the family, of course, they will worry. Then you have to be able to explain to them that it just looks that way, that person actually isn't uncomfortable, even though it's it seems that way because they breathe fast, for instance. So I think those even medical issues sometimes would be helpful to know. But of course, how do you actually, what are the steps? Also, when do you give morphine? How do you do it? Do you do it subcutaneously? Do you do it intravenously? What does that mean? I think it's also an important part. So just that medical part. And I think there is also a huge part which you have to discuss socially. So how do you discuss with family or with patients, how to introduce the idea and what that means, because people don't know themselves what palliative care is. So I find it very difficult because sometimes they think it's euthanasia. It's not the same thing. So you have to be able to explain that. So we've covered that during the studies, but I feel like it could have been covered a bit more extensively.
Has there been moments where you actually delivered palliative care and moments that have been really impactful for you?
So sometimes it's a bit personal, and then they tell you a story you can relate with, and that's the patients you remember. And also the family around. They are very happy that you're coming, that you can explain what's going to happen if someone's going to die, or what can happen in the future, and can think with them how they can arrange things. So also the family, when they are thankful and they are happy that you're coming and you have time, that's important moments. And that's why I'm doing this job.
I always found it very difficult with people who were young and who were fine until something happened. And neurology is always, it's often a bleeding, for instance, or a huge stroke, which made somebody who was perfectly fine, had small kids and lived their lives, just in 1 second they turned into somebody who was who couldn't do anything. They couldn't eat, they couldn't drink, they couldn't speak, and their prognosis was rapidly deteriorating. So I always find it very frustrating. And like I said, I always remember saying, well, yeah, but maybe we should call the neurosurgeon. Maybe we should just try. Maybe we should just try to save them. I found it very difficult to accept. So I think that's very difficult. But I also have experienced elder patients who have lived their lives, and they were in the hospital while they also experienced something similar. But then their families said, well, actually, it's the most beautiful way to let them go, because they're next to me and they're drifting from sleep to a little bit of awake and a little bit of sleep. They're comfortable, and I can have my last farewell. I can still see them. Probably they feel like they have the time to say goodbye. So I think it's it's very it can be beautiful, and it can be beautiful for reflection for the family when they can say, yes, they've lived their lives the way they wanted. I'm happy that I can let her go in such a way that I'm comfortable with it, she looks comfortable, or he looks comfortable, and that you can facilitate it as a doctor. So I also found it, the beautiful aspects of it.
I didn't quite know when I first started my F1 that I would actually be involved with so many sort of, palliative care, end of life care scenarios. I think, there's several that have stuck with me. I think it's probably also due to the nature. It's sort of my first job as a doctor, and you just naturally do take things home with you. Having cared for people who have died because of COVID, and you have basically seen them sort of coming in to the hospitals with classic symptoms, shortness of breath, and then they continuously got worse. You were involved with talking to the relatives, basically that whole process, and then eventually taking care of them at their end of life, and seeing them pass away due to COVID. I think just all of that has been definitely, like in the past months, something that has impacted me a lot.
And also, I think you just see it every day in hospital, and in GP as well. But in hospital, it's right there in front of you, and you see these people who are towards the end of their lives, and there are decisions being made in an acute hospital where perhaps the person in the bed next to you is being treated for perhaps an acute infection or something along those lines, and will be discharged in a week's time, and somebody who possibly, if they do make it out of hospital, will not be living for sort of longer than a few weeks. And actually, I think that's really where the majority of the learning about palliative care happens, in that real environment where it happens so frequently.
My first question would therefore be, how do you define palliative care, and what does palliative care mean to you?
Well, as you know, there are official definitions of palliative care, what it is all about. But it's basically, for me, it's caring for severely ill patients, and which is a little bit still unusual to regular medicine, to real medicine, as you might call it. And therefore it's a little counterintuitive to many still in medicine, and also to much what you have learned in medicine, in med school. Maybe also a little bit counterintuitive to what your experience currently is as a junior medical doctor. It's sometimes hard to get the palliative care messages across, I find, because people are doctors. Our system is very much geared still towards cure, towards life prolongation. And I think it's a psychological hurdle to think about dying, to think about the end of life.
Palliative care is really nothing more than just taking good care of patients and their family. It's nothing different from curative care, but it's, on the other hand, it is different because it's a care that it's in the time that the patient and the family have a lot to think about, a lot to suffer also. So you need to be there for them, probably more than in curative care.
How was that for you when you were a junior doctor? Did you have those same sentiments, or was there an instant connection? Can you elaborate a little bit on that?
Well, in my time, it was not something that was really spoken about, because it was something for other doctors. It was not for you to do. So in that time, you were more raised as a curative doctor, and everyone wanted to be a surgeon or wanted to go to developing countries in Africa and do your stuff there. So it really wasn't an issue. It was simply not spoken about.
I was introduced into palliative care basically by a severe illness in my family, my brother, and therefore I was open to these questions. And I think all of you listeners, everybody has experience in that. And I think it's the question whether to take this up and open or to close your eyes, which are both reasonable psychological reactions to this sensitive existential topic. But for me, it was the reason to join in a lecture 100 years ago by Richard Lemmerton from St. Christopher's Hospice, who came to Munich at that time and gave a lecture. And I approached him because I knew I had to do a medical apprenticeship, or whatever you call it, in my medical studies. And he suggested to go up to a Scottish hospice. And this is where I went for a month as a young medical. It was my first clinical encounter. And there I saw that A, medicine can look for patients who are severely ill, and B, medicine can make jokes, can be humorous, can be relaxed, even in those severe instances. And when I drove or went with one of the consultants there to a home visit, and he drove us there. He said, medicine is like this gear in my car. There are several gears, and you must know which gear to take in what clinical situation. I think this is quite something. You must know which gear you have to take, which medical gear in which clinical situation. And that's hard to know and to get the experience in all of those gears, from emergency medicine through to palliative care, and then to adapt them to the clinical situation of your patients in front of you.
So times have changed, obviously, and during your career, you have gained an interest. Was there any particular moment that you realized you started to get an interest in that? Can you elaborate a little bit in your discovering process of your interest in palliative care?
It came up to me naturally. This, of course, is something which, and I immediately was attracted to that idea of medicine, immediately.
Well, first of all, when I was a young doctor, studying to become a young doctor, I was in a hospital and I had to take care together with my colleague. We were both at 25, I think. We had to take care of a young woman who was about our age, and she had a meningitis, so she was in sort of a coma. And it was very sad because we had to do daily arterial blood gas in her leg, and she suffered. She was sweating, she was painful, and we couldn't do much for her. There was no family, so we had no knowledge on how to take care of her. But instead, at that time, everyone turned away, including us. And I still feel bad about that because she died eventually. And she was just lying in the hospital bed.
And what are current key issues or challenges that junior doctors may face while delivering palliative care?
Well, I think one of the key issues is that you have enough palliative care education, and that you also know who your helps are, your aides are, the palliative care physicians and nurses who work in your hospital, when you work in hospital, of course, as a young doctor, or if you work as a young doctor elsewhere in a nursing home or in a home situation, that you then know who you can ask for to help you, and that it's okay that you get help. So, but I think also every young doctor should have basic training in palliative care, so that you know what is your task, and you also know what you don't have to know, that you can always ask others to help you. And in that way, you take away a lot of the hobbles. You take away a lot of the barriers. For to try to do good palliative care. And I think once you take the first step, and you really see that just being there, just asking patients and family, how are you? What can I do for you? You don't need to do heroic things. You don't need to know every medication that is possible or every intervention, but just being there and being kind. That is the first step. And then it becomes more and more easy.
Well, I think it's your psychological attitude towards these topics. Once you're open, once you can confront yourself with the issues of death, dying, bereavement, finitude of life, of your own life maybe as well. Once you're open to these issues, you are open to what the patient and the relatives say. You're open to learning more. You're open to feeling these things. Otherwise, you close your eyes, and it's maybe helpful for yourself, for your personality, because you're not harmed yourself, but it's not good for your patients. They may collude, actually. There's a lot of collusion. They may collude and tell you, well, I don't want to know about the end of my life. I want only to hear about cure, which is maybe hopeless anyway, and you will collude and say, oh yeah, there's cure, there's the possibility of a phase 1 trial here, and a new wonder drug coming from America there, things like that.
Do you think that is something that medical schools should implement in their curriculum?
Must, not should.
No.
It's essential.
It's a must. Okay.
You can't be a good doctor, practicing doctor. You can be a good doctor in a lab, of course, but not practicing doctor if you don't at least consider these things. You don't have to become a specialist. There are only a specialist palliative care physician. I'm not arguing for that, not at all. What I'm arguing is that every physician has to have knowledge, skills, attitudes around palliative care. It's essential for your work, for your life, for your own life balance as well, actually.
Well, in the Netherlands, we've only just recently made up a core curriculum on palliative care for medical students and also for the young trainees and for the residents. So it's a stepwise education curriculum. And what is necessary is that every student has training in that. And it's about basic skills, it's about communication. And we need to incorporate lessons on that into every curricula in the Netherlands. And not every academic center is there already. Some are behind, some are a little bit better prepared, but it needs to be implemented structurally.
Should be incorporated everywhere and from the very beginning, of course. But there is also the third goal of medicine, which is quality of life improvement, even early on, of course. So this aspect of medicine must be incorporated in all the curricula in some aspect, more relevant than others, across the whole spectrum, of course, because you are growing through med school and the other professions as well. You mentioned it. You're growing, you're getting a different experience, maybe counterintuitive experience to what you're taught because of the culture still there. And then you have to reflect it. And so you're growing through these all steps. Yeah.
Yeah. You need to have some passion. And enthusiasm is the most important one to stimulate. And I think you need ambassadors, maybe young doctors who are not that old, who can really say, well, this is the way to go, and you should hop on the train and follow me, because end-of-life care is important, palliative care is important, and it's all about you being a doctor. You want to help people, so it also includes palliative care or end-of-life care. So education is one way. The other way is maybe having it already in the middelbare school, in the
secondary school or high school.
Secondary school or high school, yeah. And try to make it more sexy. Try to put it into a game or into something on the internet. Make it lively. That's what we need. We need to step away from only fear, and that it is very sad all the time, because it's not. It's also, you can have a really good laugh with people who are very sick and their relatives. And it's about life. It's really about life. It's about why we are here on this planet. So
there must also be a formal training in leadership in palliative care. It's, I think, different from other areas of medicine. If you look into heart surgery, it's a different kind of personalities there. You might need different leaders there, but for us, we have highly motivated people who really want something. They are very emotional as well. Sometimes they can work a lot with each other, which is important. Work as a team. They want to work as a team. It cannot be leadership top-down approach at all. So we really have to think what type of leaders or the leadership skills we really need in palliative care.
And if you could give one piece of advice for junior doctors that are starting out on their first job with regards to palliative care, what would you say?
Oh, perhaps my advice would be to not be afraid. And if you are faced with a patient or the family of a patient who are really ill, not to follow your instinct and turn around and go away, but just enter the room, just sit there. You don't have to say anything, just say, "Hi, this is me, how are you?" And then they will start talking. So, and then if you do simple things like that, you really become into the person who is ill. And then you become enthusiastic, because that's why you chose to become a doctor. You are interested in people. So don't step away. Feel not afraid. You can do it. And refrain from talking too much. Just sit there, be there. It's all about presence.
One piece of advice of delivering good palliative care, I think being open to what the needs of the patients are, first of all, delivering good care, and being open to develop yourself as a person into these questions of your life. It might help you later on as well.
Thank you so much for joining us today. We've only just touched up on the beginnings of palliative care and the intricacies and challenges it holds for junior doctors. We've talked about their personal experiences, about barriers and essential skills, but also about ways to change the palliative care landscape for junior doctors. We talked about ambassadors and leaders to instigate these changes, about a better implementation in the medical curriculum, and about a certain personal openness and willingness to participate in palliative care. And if you want to share your thoughts on social media like Twitter, please use the hashtag HLA Live so we can find each other. So once again, thank you so much for joining today, and let's keep talking about palliative care. See you next time.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marluana, the director of the HLA, and it's a good night from all of us.